Welcome, everyone. We're going to give it a minute for participants to join. For those that have joined, please go ahead and read the disclaimer that we're posting in chat. Alrighty, I'm going to give it a few more seconds. Okay, we're going to go ahead and get started since we only have an hour. Hi, everyone. I'm Jasmine with the Community Engagement team at the department, and just a few announcements before we begin. We're offering Spanish interpretation today, so I'm going to give instructions on how to access the Spanish channel. Para escuchar esta reunión en español, haga clic en el globo blanco en la parte inferior de la pantalla con la etiqueta Interpretation. Luego haga clic en Spanish y seleccione Mute Original Audio. We're also offering ASL interpretation for today's meeting. The interpreter has been spotlighted and closed captioning is active. This meeting is being recorded and it will be made available on the department's YouTube channel. And I'm going to stop there. Dr. Schwartzman, if you could advance one slide. There we go. Materials were emailed, but we're also posting them in the chat for you. You may send written comments via email to autism@dds.ca.gov. Next slide, please. Just some webinar tips. Chat is not available, but please go ahead and use the Q&A button to submit questions and comments. And we're going to have a Q&A session during the last 10 minutes of the webinar. And again, you can submit your questions using the Q&A button. And you may also use the thumbs up to upvote a question. You can view today's slides in English or Spanish. Just hover your mouse to the top of your screen and select the tab for English or Spanish slides. Lastly, please take a minute to complete the survey that will appear as you exit the webinar. Thank you, and I hand it over to Carmen Reese Ochoa to introduce today's topic. Thank you.
Thank you so much, Jasmine, and welcome, everyone. I am absolutely delighted to introduce to you our distinguished speaker this morning, Dr. Jessica Schwartzman. She is the director of the Training and Research to Empower Neurodiversity Lab at the Children's Hospital Los Angeles and clinical psychologist for Autism and Neurodevelopmental Services in the Division for Developmental and Behavioral Pediatrics. She also holds professorship at the USC Keck School of Medicine and Vanderbilt University Medical Center. Her clinical and research career is focused on diagnosis and treatment of depressive and anxiety disorders and risk management, and holds special expertise in these topics at the intersection of neurodivergent children, adolescents, and adults. Please join me in welcoming Dr. Jessica Schwartzman.
Thank you, Carmen, and everyone for the lovely introduction. I am Dr. Schwartzman. I use she and her pronouns. I'm excited to be with everybody today to talk a little bit about the work that I do both in my lab at Children's LA, but also clinically, an area that's really important to me. So I'm going to cover suicide risk and prevention strategies, particularly for individuals who identify with an intellectual or developmental disability, and families and other members that support them. And these are folks that are also working intimately with the regional centers. I will say that this is a very big and important topic, and it is challenging for any lecturer to cover everything that we need in an hour. So what I've done, both as a psychologist and also a sibling of someone with autism and intellectual disability, I've thought a lot about what do I feel like we can share in an hour that might be key takeaways and leave people with practical tools. So I recognize that I won't be able to go over everything that I want to, but I'm going to hopefully give a short overview today. So in terms of my disclosures, I think some aspects of my work and identities are important because they might influence this presentation and the perspective that I have when it comes to this work. So I don't have any conflicts of interest to disclose. My research lab here at Children's Hospital Los Angeles is supported by several federal and international funding agencies. Professionally, I have received training both in mental health care and working with people with IDD at UCLA, Stanford, and at Vanderbilt. Personally, I am an older sibling and a caretaker of an autistic young adult with intellectual disability who is also a client of a regional center in California. I do want to acknowledge that given the nature of this topic, my presentation may be triggering or stressful for people attending. So I highly encourage anybody who feels overwhelmed to please step away from the presentation. You can mute me, blank your screen, do anything that you need to take care of yourself during this presentation. I also want to acknowledge that science is a team sport, and I'm really lucky to have a great team of folks working with me in different areas on some of the research that you're going to see today. So I'll thank my lab members, both at CHLA as well as former ones at Vanderbilt. I want to thank the funding agencies in the bottom right that have contributed to a lot of the work that you're going to hear about. But most importantly, I want to give an acknowledgement to my autistic collaborators in the top right corner. These are autistic adults with lived experience of mental health differences, challenges in accessing therapy, regional centers, and they bring so much insight and perspective over almost 6 years now working together in the work that you're going to see today. So I want to acknowledge them and thank them, most importantly, for bringing such detailed and lived experience to some of the work that you're going to hear. So in terms of what we want to accomplish today, first I'm going to give a brief overview about what we know in terms of suicide risk in the IDD and autism communities. Next, I'm going to discuss some emerging evidence-based strategies that we have for families and people who are experiencing suicide. Lastly, I'm going to go over just some brief recommendations for how to keep yourself or someone you're supporting safe if they're experiencing a crisis. Okay. So this is a really important question that I have asked for many years and an important question that guides a lot of the work that me and my team do here at CHLA. And it's this basic question, which is, what do we know about suicide risk in people who identify with IDD? Unfortunately, we know very little. So the quote at the top is actually pulled from a federal agency that surveys what is available in terms of mental health for people of different communities. And this quote is really representative of what we see across agencies, what we see in the research, what we encounter in clinical services, and the reality of families every day, which is that there's limited data available on suicide and mental health outcomes among people with disabilities. And this is really challenging because we know as a community for decades that mental health is a really serious area to focus on. Fortunately, in the last 5 to 7 years, we do have some emerging data that help us understand this gap a little bit. Some of the work that we see is that people with IDD or other developmental disabilities are 2 to 3 times more likely to experience depression and 6 to 8 times more likely to experience anxiety than people in the general population. Unfortunately, we know that victimization, anywhere from physical, sexual, emotional, or verbal victimization, is far more common among people with IDD than other communities. More recent work has showed that this population is also more at risk for both thinking about suicide as well as going on to actually attempt suicide. And unfortunately, due to many systemic barriers and historical exclusion, we also know that there's very few outpatient services available to help people in crisis. So what ends up happening is that people with IDD are far more likely to utilize emergency departments and be admitted to psychiatric inpatient units than the general population. And I want to pause to highlight these statistics because they're really alarming if we think about the fact that the US more broadly is in an active mental health crisis. If you've read any newspapers, magazines, seen any news on the TV, you will know that we have been in an active mental health crisis that has been exacerbated by the pandemic. So to see these statistics be that much more significant compared to a population that's already in distress really highlights the fact about what a serious issue that this is facing this community, and really a race against time to figure out ways to get tools developed and out in the community quickly. And ultimately, what these statistics show is that these effects are extremely costly financially, emotionally, physically, not only for the individual in crisis, but for the family members or others supporting them. This is really expensive and costly and time consuming and hard for the broader communities and school systems and employment areas. And I think at broader systems level as well, we can't simply continue without outpatient options. So I just want to take a minute to highlight that this is the challenge that many of us face and why we're trying to take steps forward to fill those gaps. So I'm going to give some quick facts that dig in a little bit more on this topic of suicide risk in the IDD and autism community. So as I shared, on the previous slide, people with IDD are far more likely to both think about and attempt suicide than the general population. And I really want to emphasize this message because I know as a sibling, as a psychologist, suicide risk was not always on my radar for people I'm working with, friends that I have who have an IDD. And so I think having this in our collective awareness that there is a higher risk that this could happen is really important. What we also see is that people with IDD of all ages are at risk for suicide. So there's not one particular age group that is more likely. We see that really suicide risk can happen across the developmental spectrum. Some of my work shows that suicidal thoughts can actually show up in youth with IDD who are as young as 6 or 7 years old and can actually persist over their lifetime, though it might be to varying degrees and severity. Some of my work does show some important things that we can think about as providers and family members that can help keep people in crisis safe. So one of the things that we have learned is that overdosing is the most common method of attempt reported by people with IDD. And I think that this is particularly challenging because we also know that people with IDD generally are more likely to be prescribed psychiatric medications than the general population. So what that means is that people have more access to lethal means like medications, which can make safety tricky. We also see in younger folks that methods such as strangulation, stabbing, or even jumping out of cars on freeways or other fast, dangerous areas are common methods that people have reported they've thought about or attempted. The other thing that we know is that suicide risk does cut across sexes, gender, race, and ethnicity. It also cuts across socioeconomic status and region. So again, suicide risk is pervasive throughout the IDD and autistic communities. And my talk today is really focused on the individual at risk, but I will acknowledge that we have some work coming out about significant levels of stress, not only in parents and people who support those with IDD, but also some emerging signs that they might also be at risk for suicide. I won't have time to talk about that population. I do acknowledge that more work needs to be done in that area, and I'm going to continue to focus on supporting an individual. So when we think about suicide, what I often get asked as a clinician, as a researcher, is what will cause my child or adult to experience suicidal thoughts? And this is such a great question, and the answer is always really tricky. We know that suicide is not due to one single factor. We know that instead, suicide is usually contributed to by multiple things happening at the same time. So some things that we know that might indicate that somebody's more likely to have suicidal thoughts are people with a family history of suicide or experiencing current mental health distress. We know that substance use, lack of an accurate diagnosis or treatment plan can contribute to suicide risk. We know that chronic illness and pain is also another contributing factor. And when multiple risk factors are happening at the same time, it increases the risk of suicidal thoughts and attempt. So again, not one of these in isolation will cause the risk, but really as caregivers and providers, we need to be thinking about all of these potential areas because they can increase somebody's likelihood for suicide. At the same time, I think it's also important to think about what can protect against suicide. So similar, unfortunately, there is not one particular strategy or thing to do that will prevent someone from experiencing or attempting suicide, but instead it's a multitude of protective factors. So the more of these that we can put in place in an individual's life or in family members and caregivers to support them, the lower the risk over time. So this can include appropriate mental health treatment, having close relationships, even having an IEP or a 504 plan, we know can actually prevent or help reduce suicide risk. And we also know that people who have inclusive environments and stable supportive employment are less likely to think about suicide. So again, these are important things that we're always thinking about how to build more to, again, increase that support. What I also think is important to talk about is some common misconceptions that we can have about suicide risk, because I often get very relatable and understandable questions from parents when they're nervous about asking someone they love if they might be at risk. So often I will hear people say that asking about suicide will increase the chances that an individual thinks about it or even attempts it. And that's a logical, worry. I hear that a lot. But we've actually had multiple studies, both in the general population and in the IDD populations, that asking about suicide does not increase the likelihood that it will happen. It doesn't plant the thought, it doesn't cause someone to go on to attempt it. And actually, asking about suicide increases safety because it allows people to detect whether someone's at risk. Another common myth is that suicide only affects certain groups of people. I hear sometimes that, suicide risk can only affect males and can only affect them when it comes to firearms or things like that. But again, as I kind of hinted at earlier, suicide risk unfortunately is universal among the IDD community. But some of our work shows that particularly folks who identify as autistic might be more likely to experience suicidal thoughts at some point in their life. Another common misconception is this idea that the only people that can meaningfully intervene or prevent suicide are mental health providers. And again, that's an understandable thought because as mental health providers, we do provide a lot of suicide prevention supports. But actually, we as providers don't work in a vacuum. We actually really need individuals at all levels of society in someone's life to coordinate and come together to increase safety. So, for example, as I hinted earlier, things like an IEP or a 504 plan or a stable job or being connected to appropriate healthcare, these services can actually have more of an impact on suicide risk than simply going to therapy. And so, often when I give this, people don't realize that something like an IEP can help actually reduce the suicide risk, but it's very true. And so thinking about not only preventing suicide through mental health care with providers, but also thinking about all the other systems that's in an individual's life and how critical those can be. Okay. So I briefly put together a few recommendations based on the very limited evidence that we have for how to support yourself or someone else who might be in crisis. I will say that these are general recommendations. I, as a psychologist and sibling, know full well that not every intervention works for everyone the same. There is no one size fits all. I also acknowledge that unfortunately, because of historical exclusion of people with IDD from research, we have very few studies that can guide us to the best appropriate ways to help someone in crisis. So what I have done is synthesized what I can from what we have available, and I'll share some of those recommendations with you today. So if you're an individual who identifies with an IDD, who might be autistic, or other types of identities that you think are relevant and salient to you, some of the things that you can think about are safety plans to support yourself. So I've put a link at the bottom. I believe it will also be available through the webinar. This is a great free and publicly available safety plan through the Columbia Lighthouse Project. What this does is it's a self-guided plan that you can make when you're thinking about how to prepare for a potential crisis. So it often walks you through how to think about your warning signs that you might be in a crisis, things that you can do to feel better in the moment if you are experiencing suicidal thoughts. If those don't work, it helps you walk through and identify places you can go for distraction to alleviate the thoughts or people to talk to. It also includes your support people, someone that you can trust and tell that you're not feeling safe or that you need extra support. This could be a friend, a parent, a school teacher, a counselor, a boss, really anybody who's an adult that you feel trusted and can support you. It also gives some professional resources and supports that you can use and access in the event the suicidal thoughts or crisis becomes really big. And this also includes some 24/7 crisis hotlines, as well as for folks in LA County, we do have things like the mobile crisis unit. So I won't be able, just given time, to go over all of the ways that this plan may be beneficial, but I just wanted to highlight it and include access to this free resource because many people that we work with have found these plans to be helpful. Again, it's not universal. That's not one size fits all, but from what we have available, we do know that this can be successful. Okay. I've also included here, and we did put a paper out on ways that we can adapt safety plans further to best fit people with IDD. So for example, when we think about helping someone identify that they're in crisis, we can think about specific warning signs like feeling overloaded by sensory systems, feeling burnt out by social interactions, and really identifying those unique signs that you might be starting to feel in a crisis. Next, in terms of coping skills, there are many that people in the general population, in the IDD community use and like. People may play an instrument to distract themselves from their thoughts. People may spend time with a pet, or they may read, watch TV. All of those are great, particularly if they help. But there's some specific ones that can be helpful for the IDD community. So time alone in a quiet, sensory-friendly environment can be helpful, as well as engaging in your preferred interest. If that's anime, if it's video games, often spending time in something that you enjoy can help distract you from those suicidal thoughts. If those strategies don't work, we think about social support. So this is places to go or people to be around that can provide distraction. So for some people in IDD community, they enjoy being around other people. It helps distract them. It might even help them feel better. But for others, that's not true. Spending time around others may be more stressful or might exacerbate things. So really considering whether or not that intervention step will help you or not. What we have seen, though, is that some people will engage more in their online communities and that can really bring some relief. And it also reduces the work that it takes to interact with people in person. When it comes to reaching out for professional support from whether it's a counselor or a psychiatrist or a pediatrician, it can be really hard to ask for help. This is a universal human experience, right? It's really difficult to ask for help. But some of our work shows that in particular, people with IDD struggle with how to ask for help. And it's not that they don't want to ask for help. They're delightful and talented. It's that they're not sure the mechanics of how to express that they need help. And so chances to role play or practice how to call the therapist, how to send a message to the psychiatrist can relieve some of that anxiety about reaching out for help. Lastly, we always think about the environments that we are in. One of the things that we know that can lead to suicide attempt is simply having access to things that are lethal. So for example, there are studies that show that people are far more likely to attempt suicide simply if there is a firearm in the home. even if it's locked up and put away, simply that it exists in the home substantially increases the likelihood that it may be used for suicide attempt. So when we think about our physical environments, always thinking about, is there anything in the moment that could be dangerous to someone who's in crisis? So this might include medications, Advil, it may include kitchen knives, scissors, anything that might be quick and readily available. We want to think about moving away, hiding, storing, or even removing from the home altogether so that as somebody is going through a difficult period, they can stay as safe as possible. Once somebody, again, re-enters a more safe period, we might bring those objects back. And again, we can think about how that will work individually for different people. Again, it's really challenging to summarize our paper in just a few minutes. So it is free and publicly available. And I know these slides will be available as well. I'm going to include a few other resources that I think are fantastic if you identify as someone with IDD, but these can also be helpful for people that support you, family members, caregivers, or whoever. So these are specific crisis resources that were developed for and with autistic people or those who have IDD. The first is, I'm going to highlight here, the Autism and Suicide Prevention Work Group. So through this website, they have multiple free and publicly available resources for managing suicide risk. So for example, they have a great resource on how to call 988. That is a common 24/7 crisis hotline that many people in the US can access. It can be very scary and unpredictable without a resource like the one they provide. So again, I think that's a great organization to look through if you're looking for resources. Myself and others also have partnered with the American Foundation for Suicide Prevention. So this is one of the largest foundations in the US that's focused on this topic. They not only have an autism webpage, but we are working actively on making free and publicly available resources for people in crisis, family members, those who support them, mental health providers. So stay tuned as we continue to roll out those materials online. Lastly, I do think that the Autistic Girls Network, this is a charity run out of the UK for and with autistic people. Despite the name, they do have resources for people of all genders. And these have great resources, not only about self-harm and suicide, but they also have great resources about a neurodiversity identity, navigating school systems, handling employment, and other areas that are really important. So again, we'll make sure that everybody has access to these, and I highly recommend checking these out. They're really great resources. So I'm going to briefly show some of the resources that are available as a way to kind of give you a little bit of a preview of what they look like. So this particular one is from the Autism and Suicide Prevention Work Group. That's the first one that I mentioned. Again, we have the link available to access this very same resource that I'm going to show you. This particular one is 988 information for the autism community. What I will say is, even though it says the autism community, we've really broadened this to be a free and available and useful to people who have neurodivergent identities and different ways of communicating and asking for help. So as you'll see on the resource, it gives basic information about what 988 is, what will happen when you call or text 988, what to do, how you can access it. We also encourage some reasons why people might call 988. I think a lot of people think that it always has to do with suicide, and that's not the case. There's plenty of people at 988 that can help with any moments of overwhelm or distress, or if there's substance use or things like that. So even though 988 does include suicide prevention counselors, it does include counselors that can go over a variety of other crises and overwhelm moments and provide support. And then we also detail what can happen based on what you share during these calls or texts. So again, it's not a comprehensive and fully complete resource, which we recognize, but this is a cheat sheet that will hopefully help when people feel that they need to contact 988. Here's another resource. This is one that we call Reasons for Living. We know that identifying reasons for living can help reduce suicide risk. So through this worksheet, we help people think through some of the reasons for living, how to create your own list, where to keep your list, when to use it. And again, this can help guide you through ways to keep yourself or someone else you're supporting safe when they do have those crises or difficult moments. Okay. So now I'm going to shift a little bit to family members, caregivers, or other people, mental health professionals, anyone that's supporting someone in crisis. And again, this is not an extensive or comprehensive list, but I think can be a quick resource or cheat sheet to help as you're thinking about approaching and talking to someone that you're worried might be in crisis. So the first thing that we always think about is the environment of where you're going to talk to someone who's in crisis. It's always best when you can to pick an environment that's private, quiet, and sensory friendly. So low noise, minimal lights, odorless if you can. I also think about making some regulation items available in that environment if I can. So for example, in my research studies or clinic, I always carry around my fidget bag. It's just full of sensory items and fidget toys. It even has some snacks and water because we know that the physical body, when it's activated, can make suicidal thoughts worse. So simply having little tips and tricks available can help. I'm also mindful in the environment of who is present with me if I'm going to talk to someone about a potential crisis. I always think about, will the other person with me provide support to the individual, or will they add to stress? And this looks different for each person. But again, thinking about sometimes multiple people can be stressful, whereas sometimes multiple people can be helpful. So just thinking about that before you approach someone who you think might be in crisis. So once I've thought about the environment, then we think about our delivery. How are we going to ask somebody about whether or not they're experiencing suicidal thoughts or behaviors, or they might be in crisis? So I always ask myself, is it better if I do this virtually through a phone call, through a Zoom, or is it better to do it in person? And I have a lot of flexibility with that. Some people with IDD prefer in-person conversations, and others prefer electronic. So I always think about that before I approach someone. Other times I think about when I go to ask a question verbally, I feel comfortable communicating verbally, but that might not be the case of the individual I'm talking to. They may prefer to communicate through writing me notes, sending me text messages, typing in a chat, pointing to pictures. So I think a lot about being open to different ways that the individual might express their needs and coming ready with those options so that I can offer them in the moment to make it more comfortable. I also truly believe that all of these response options are valid. We don't have to talk about suicide out loud for us to be able to identify real risk. The other thing that's really challenging, and I'm going to spend a few minutes to talk about the reality of this last piece. It is really challenging and it can feel scary and nerve-wracking to ask someone if they might be in crisis. And it's not because we think that they're a burden or that we think that there's anything wrong. It's that it's scary to know that someone we care about might be in trouble. And anybody can relate to that feeling. It can be a nerve-wracking one. And so I often, mentally kind of go through my own checklist and really think about my reaction to this conversation, to talking to someone about suicide risk. Because if I cry, if I raise my voice, if I get upset, if I become stressed or appear stressed in my behaviors, it really can amplify their experience in a negative way. So I'm always mindful of my tone of voice, the volume that I use, my emotional reactions, my nonverbal behaviors to make sure I'm as calm and as neutral and supportive as I can be. And again, as a parent, I understand that's really hard to do when you're worried about your child or someone you're supporting and they're having a hard time. But I can promise you from the work that we are doing, the more regulated, the more calm and supportive that we can be in that conversation, the more life-saving it can be. It is the number one thing that we hear from teens and adults that we work with who have had suicide risk in the past is that when they share with someone, it's a pivotal moment for them. They're being vulnerable and acknowledging that they're at risk. And if they are met with tears or frustration or being ignored or any type of invalidating experience, it not only makes their crisis worse in the moment, but it really reduces the likelihood that they'll ask for help in the future. So again, as best we can, trying to stay as regulated and supportive when we're talking to someone about whether they're in crisis. I'll share a few examples of kind of how we start this conversation because, again, I get a lot of questions about this and it can be really hard to know. And so if we provide some type of supportive opening statement, really the background of why we're asking them if they might be in crisis, by providing that rationale, it can help make the conversation feel more supportive. So always starting from a place of support or love. I thoughtfully point out changes that I might notice in the individual's behaviors, thoughts, or their emotional responses that might make me think they're in crisis. So, for example, if I see somebody who might be engaging in self-harm more or saying more negative thoughts about themselves or the future, and if that represents a change from how they usually are, I might sensitively point those out and become curious about why those changes might be happening. Again, the curiosity is we don't want to blame. We just want to simply be curious about whether or not the things we're noticing might be a crisis thing, might be a sign of stress, or maybe there's something else going on. So if we're curious rather than kind of judgmental or prescriptive, it can be helpful. If someone is in crisis or showing these changes, it can be helpful to normalize that. People who experience crisis feel very isolated. They feel that something is wrong with them and that it is a unique experience. And so if we can recognize that actually it's a very common human experience, particularly in the IDD community, that can be really normalizing. And when we point these changes out, we ask if the person might be experiencing a crisis or having suicidal thoughts. And I'll get to that in a second about how we can directly ask. But the goal is we want to first say that we're supporting them because we really care. We've noticed changes in X, Y, and Z, and we're curious if these changes might tell us that you might be in a crisis. That's the gist of how we would start. So again, we start with support. We thoughtfully point out the changes we've noticed that make us concerned. We have curiosity about why those changes might be happening. We want to normalize that people can have negative self-critical thoughts. They can have suicidal thoughts, particularly if they're stressed. We want to inquire if these changes suggest they've thought about suicide, and then we'll ask some follow-up questions to assess. So again, these are not perfect examples, but I've included one here. And in the interest of time, I won't have a chance to read it, but this kind of covers all of the key areas that we can use if we're going to approach someone to ask if they might be in crisis. Again, here is another example, wanting to talk for a few minutes, identifying your role and why you want to support the person, noticing the changes, and asking if they can support and talk. So once we've built our opening statement and we've begun to approach this idea, then we really need to use direct, concrete, and non-judgmental questions about suicide risk. So for example, asking questions like, are you having thoughts about death or dying? Are you thinking about suicide? Are you thinking about hurting yourself? Are you having thoughts about sleeping and not waking up? Are you having thoughts about wanting to be dead? Again, there's lots of very concrete examples that we give here. The more concrete and specific we can be, the easier it is for the individual to answer. And it also gives us really helpful information about the severity of someone's crisis and what we need to do to best support them. Once we know that somebody has had any type of thought about death or suicide, it can be helpful to learn a little bit more about how much these thoughts are impacting them. And I always think about FDS. So I think about the frequency that something's happening, the duration, and the severity, and I'll cover those in a second. So frequency meaning how often are the thoughts or the urges happening for someone? So instead of saying, well, how often do those thoughts happen? That's kind of an open-ended question. I usually am very concrete and say, do you experience the thoughts once a week, 2 to 3 times, 4 to 5 times, or multiple times each day? Once I know the frequency of something, I want to know the duration. How long do the thoughts last when they happen? Right. And again, I have very detailed and concrete amounts of duration rather than saying, well, how long do they last? Because that might be overwhelming to answer. And then the last thing is always thinking about severity. And here, instead of saying how intense are the thoughts or how severe are they, that can be really difficult to answer. Instead, having concrete questions like on a scale from 1 to 10, 1 being they don't bother you very much, 10 is they're consuming your life and taking over. How intense are the thoughts? And again, by picking a concrete numerical answer, makes it a little bit easier for the person to convey their level of distress. So once we have a sense of whether the person is in a suicidal crisis and the extent to which it's happening, it's also important that we give space for their response. So for people with IDD, it's really critical that we allow extra time for them to process your questions. So often when I ask, have you thought about killing yourself? I'll have individuals who wait a while. They might sit in silence for a few minutes. They're not trying to be, disagreeable. They're not trying to ignore me. They simply need time to process the question and to really have their own journey with it. So giving time is really important. I also check if my question was clear enough, or if other follow-up questions might be helpful. I always directly make it clear what my support is. What do you need in this moment? What can I do to help you in this moment? And remembering that there are no right or wrong, amounts of time that an individual needs to respond or a format, that really being open to their experience is important. And again, as we mentioned, your response in this moment is really, really critical. I cannot emphasize that enough. So, as I mentioned, learning that somebody's in crisis can be deeply upsetting because you care about them and you want them to be safe. And so the more that you can maintain a calm, even tone and show support throughout the whole conversation is so critical. It's very common after the fact. You may have your own emotional reaction separately from the person because you love them and you're worried about it. And that's okay. But we really want to keep that separate so that the main goal is to focus on support in the moment. Once we get a sense of whether someone's in crisis, then it's really important, again, to think about what resources are available. So ahead of your conversation, I highly recommend accessing some of the resources that I've shared, thinking about local mental health resources that you and the person have access to, whether it's a therapist, maybe they have a pediatrician or a psychiatrist, who's available to contact once you have this conversation. What are online mental health resources, those crisis hotlines that are 24/7, or any other key people that you'd want to bring into the conversation to help support them. So again, we plan for these ahead of time and then have them available to use with the individual when we need them. So again, it's really challenging to cover ways to, talk to someone about suicide, ways to support and keep ourselves safe in those moments. But I think some key takeaways that I'll focus on are a few here. So one, how do you foresee yourself taking an active role in suicide prevention efforts? Maybe it's for yourself. Maybe it's for a family member or someone that you're supporting. What would that look like? Maybe as a provider, there's something new about your practice that you can think about adopting. And based on our discussion, is there anything about your perspective or approach that you would want to change? Is there something in the past that maybe if you tweaked a little bit could go better next time? Maybe there's a new resource you learned about today that you can have ready to go if you need it in the future. And what would those changes look like? And lastly, if there's any information that you can take from today to inform not only kind of your life, but also the life of somebody that you care about today and something that's practical that you can walk away with. I've included some references if folks are interested in those. And now I believe we'll shift to Q&A.
Thank you so much, Dr. Schwartzman, on providing such a comprehensive overview in this short amount of time and really answering some questions ahead of time.